We'll start with this discussion of the large bowel cancers. Today we want to review the types. This will be much review. Maybe there are a few new types or rare types that we can talk about as well. And some of these have particular treatment implications. What I really hope to help you understand is the state of molecular testing in colon cancers and where that makes a difference, where it is of no value. And then we will talk about the individual biomarkers that are in use now in many places, maybe not very much in Vietnam, but perhaps soon as more people want this service. There are two checklists, and this is probably the less important one, because this is for reporting biomarker molecular results. So maybe the most interesting and educational in terms of what is being looked at, but probably not very useful to other pathologists in Vietnam right now. Maybe 5 years, 10 years from now, maybe more. And then this checklist is the main colorectal cancer checklist. So primary carcinoma of the colon and rectum. Notice that this includes a variety of procedures ranging from polypectomy to full resection, total colectomy, and so forth. So we talked last time about polyps that have small invasive cancer. So this checklist of items might be included and reported using this checklist. So at the end, if someone is ready to try to translate this one, it may be useful for many situations. So one of the things my children used to say is, "That's not fair." Your children say that? Did you say that? So it's not fair that in Southeast Asia, only a small percentage of people get colon cancer, while in New Zealand or North America, it's very, very common. It's also not fair that a large number or a large percentage of these patients die. That's the blue line. This is mortality. Whereas here, a small percentage or smaller percentage die.
I think the difference between the incident in the Eastern and in the Western, because the diet and the mortality is different in the mortality due to the advanced treatment.
Yes. Yes, you're right. There are many factors here. Some are controllable, some are not. So some of it's genetics, some of it's Western diet, and the treatment obviously is economics and stage, type of disease, and so forth. It's still not fair. But that's a more of a moral and ethical question. We can talk about that on Sunday or Saturday or something like that. But I wanted you to see that there is a very, very big difference here, 300 in men. And it's also worse for men, see? Women have an easier time. So it's not fair between men and women either. So all of those things are things to be understood. And this is just telling you in North America how these differences play out there too. So in the North American population, African Americans, especially if they are male, have a very high incidence of colon cancer. Whereas, you know, if you're a woman and you're of Asian descent, or excuse me, you have a very low incidence relatively. So that's like 6, 7 times difference. Big, big difference. Some of these are genetic, but some of them, as you say, are diet, exposures, cultural practices, and also access to care, economics, and so forth. So these are all important things to understand when we want to make cancer go away or drive down. We have a very complex problem to deal with, culturally, emotionally, genetically, and so forth. There are some things that we can control. I can't control who my parents are or where I live very well, but I can control my physical activity. I can control my diet, my bad habits, my vegetable consumption. Here, that drives the risk down, and so forth. And here's another reason why maybe in women the risk is lower with oral contraceptives or estrogen and so forth. So we need to think personally in terms of what we can do at the same time we work to find cures and understand how to treat the disease when it does occur. But there always will be some level of personal responsibility to try to educate, to try to promote practices, public health, awareness that can make a difference. So, in pathology, one of the most important contributions we make is managing the gross specimen. Once the surgeon has removed the specimen, we have important steps to take to make sure that we can accurately identify the stage and the prognosis so that the treatment can be appropriate. This means we need to identify histology as well as margins, dissect out lymph nodes, and maybe supply samples for molecular or other studies. So here is one example. This is a rectal carcinoma. Here is the gross specimen, partly opened. And this is what's called the mesorectum. You know that term?
Yeah,
Mesorectum. Yeah. And so in pathology, it's very important to clearly examine, did the surgeon get the whole mesorectal envelope out? Where is the tumor relative to that? One of the things we can use is ink to delineate the margin. And you didn't know about ink, did you? You know about ink?
Yeah, the name of procedure is TME.
Yeah.
Total
Mesorectal incision, right. Yeah. And so we apply ink to the specimen to help us remember or orient when we look at the slide, what is a margin, what is not a margin. So here is blue ink, here is the other side, and we would ink all of this surface up here black. We would use a different color because this is also an important margin. Once it's fixed, we can also then see how the ink helps us to define relations to where the tumor is very close to that margin. And this is important. Here's a close-up view of this showing, looks like there's a little bit of tissue here, but I would use this kind of a section to say, oh, I want to have a histologic slide of this area. This is the closest to the margin. And I want to be able to provide that information so that if it's positive, maybe they give more radiation or something to help target that area of high risk. Questions about gross management? Do you fix all of your specimens overnight from colon resection? So we usually do too. Some places will do some processing fresh, or they may use rapid microwave fixation sometimes to accelerate the fixation process and allow them to handle sooner.
So
But
how long the specimen comes to your lab after your surgery?
well, we try to capture the ischemic time, the time between ischemia to formalin. So we try to encourage that to be short.
So do they fix it in the theater
Um,
operation, or you fix it in your lab?
So in the surgical suite, if they want us to do any intraoperative evaluation, they send it directly to us, fresh, and then we manage and fix. If it is a routine case, they don't want to take molecular study or anything, they may just put it in formalin at that time. So they have formalin buckets in the operating suite. But the problem is that when you do that, it fixes the outside here, but not the tumor. So you have to look for those cases and then open them to get good fixation of the inside. Otherwise, this is just all autolyzed.
So when you fix it, you open the
Yes,
the-
yes. We want, and most of our surgeons understand that and have it sent down within an hour or so. If it's a fresh specimen.
It seems that in the modern hospital, there is the automatic pathway from the operation to the pathology department.
Yeah.
So they will send the specimen very quick from the operation.
Ideally, not always. Sometimes it sits on a table
Yeah.
until the evening and someone says, why is this here? Oh, that should have gone to pathology. So it's not perfect, but we try to keep things moving with no delays. The other important part of your role as pathologists is the gross description of the kind of tumor. So this tumor that we looked at here, you see it's an ulcerated and annular type of tumor, partway around. This tumor is ulcerated, but it also is fungated, so like a fungus. And then in contrast, this is a very polypoid or exophytic, outward growing tumor. And these descriptions have some association with prognosis, and pattern of growth also has some relative good or bad or really bad prognosis. This is usually a little better prognosis, more likely to be low stage, etc. The other important thing to understand or to remember is the backdrop. So here is a slightly fungating exophytic tumor, but this is in a patient with inflammatory bowel disease. And so if we have that setting, we need to describe tumors, but we may also want to check other areas more liberally to look for areas of dysplasia or areas of other invasive occult carcinoma. In this case, we had these two carcinomas here, or maybe this is all one, but there were areas of dysplasia like this here adjacent to the tumor. Histology is also very predictive of behavior. And of course, most carcinomas are the routine type that everyone from their first year on will recognize. Mucinous carcinomas also very easy to recognize and fairly common. The serrated adenocarcinomas are a little bit more subtle and less regularly recognized. And then these other carcinomas are more unusual, but may have particular meaning. For example, medullary carcinoma, we'll talk about and show you examples, usually means a microsatellite unstable carcinoma, Lynch syndrome, in other words. And then these others are much more unusual. Choriocarcinoma, I've never seen a case in the colon. But nevertheless, these are good distinctions to understand. This is pretty much the WHO classification and the relative frequency. And one of the things for a colon cancer to occur is that it needs to mutate. It takes genetic instability for colon cancers to occur. And so one of the ways, there are several ways that this happens, that these become sort of hypermutating. And one is this chromosome instability pathway. This is the path, or this is the mechanism that most of the adenoma carcinoma sequence cancers are following. So it's the big number, 80%. And these tumors somehow develop the ability, or these cells, to acquire mutation events, et cetera, more rapidly. It may be because there's a spindle anomaly, so the disjunction and aneuploidy occur more easily, or whatever. I'm not the scientist to progress on that, but this is the pathway or the mechanism that most of these tumors are using. This is important to think about, and probably important for investigation in terms of prevention. So this may be where things like diet are highly contributory to these kinds of events, or facilitating acquisition of this type of a thing. Another major pathway is the microsatellite instability pathway. And this is the DNA mismatch repair, that's this MMR acronym here, mismatch repair, that results in the inability to repair little defects in the sequence.